Thank you so much for having me today. I feel very honored to be able to help you conclude this amazing conference. So I'm just going to talk about what the disparities are in breast cancer and where I think we need to go with regards to research and clinical care. So as many of you know, breast cancer is the most common female cancer diagnosed in the United States and in many parts of the world. 1 in 8 women in the US is diagnosed with breast cancer in her lifetime. The good news is that very few women die of breast cancer, relatively speaking. Over the course of the past 30 to 40 years, improvements in screening, as well as improvements in chemotherapy and other treatments, have significantly decreased the rate of mortality from breast cancer. But that improvement in mortality has not been universal. We have not lifted all boats to the same extent. And in particular, we know that even though white women are more likely to be diagnosed with breast cancer, Black women are 20 to 30% more likely to die. Black women are also more likely to be diagnosed with breast cancer before the age of 45, that is premenopausal breast cancer. And as many of you know, screening guidelines from various agencies recommend that women begin discussing screening at the age of about 40, but not really beginning it necessarily till 45 or 50. And that means that many Black women are diagnosed with breast cancer before typical screening guidelines kick in. And therefore, there's even a greater risk of late stage diagnosis that makes it difficult for their cancers to be cured. There are many other disparities we see with regards to breast cancer. We know that breast cancer is actually more common in the LGBTQ population. We know that women who live in rural areas are also less likely to have access to screening as well as good treatments to treat their breast cancer. We also know there are global disparities in breast cancer, with women being diagnosed at later stage in sub-Saharan Africa, as well as the Middle East and some parts of Asia and South America, relative to areas of Europe and North America. This may seem like a doom and gloom picture, but it doesn't have to be. We have actually had incredible advances with regards to how we treat breast cancer for women in the world, and especially in the developing world, we have more options for chemotherapy and systemic therapy. One of the successes of breast cancer treatment has been with regards to HER2 positive breast cancer, that is cancer that expresses the HER2 receptor. We now have really, really high rates of cure for what used to be one of the most aggressive types of cancer we have. In addition, we have endocrine therapy, which prevents us from having really widespread or progressive hormone receptor positive cancers, that is cancers that are fed by estrogen and progesterone. And as many of you know, triple negative breast cancer is a cancer that's more common in women of color. So, as I just said, there are 3 main types of breast cancer: HER2 positive, hormone receptor positive, and triple negative. Triple negative is more common in women who are of African as well as Hispanic descent. Triple negative at some level represents the area of breast cancer where we've made the least progress and have the most work to do. It is the cancer for which the only systemic therapies we really have now involve chemotherapy. And even then, we know the death rates are highest from that. Many people try to say that the reason that Black women might die at higher rates from breast cancer than white women is because of higher rates of triple negative breast cancer. But in fact, there was a study conducted by Erica Warner at the Harvard School of Public Health that actually showed back in 2015, 2016, that the survival gap between white and Black women was not related to triple negative breast cancer. That is, amongst all people who had triple negative breast cancer, Black and white women had the same rates of survival. Where the survival rates differed was actually amongst our most well-treated cancers, that is, our cancers that are hormone receptor positive. The reason I say this is because it's very easy to try, and people will certainly try to do so, conflate race and biology when they are not the same thing. Race is a social construct that is related to various factors, including immigration, acculturation, who you live with, how you eat, how society treats you. Indeed, we increasingly recognize that the disparities we observe of people who are minoritized are not so much about the way they look, but then how they're treated. So when we think about how to achieve equity in breast cancer care, one of the things we need to shy away from is from making people become biological essentialists, trying to act as if biology is what's driving all this, when we know that there are issues related to access, issues related to bias and treatment on the part of providers and of communities that prevent us from getting patients into care when they need to be seen and giving the treatments they deserve when they are seen. How do we move forward? I would argue that we've spent now a lot of time, really the past 20 or 30 years, cataloging all the ways in which breast cancer disparities exist. And that, in fact, has been one of the main criticisms of disparities research, that we spend a lot of time describing where things go wrong and how they go wrong, but not what we can do about it. Now, I push back on that a little bit because there are so many people in the United States and around the world who don't believe disparities are real. As we know, there are people who don't believe climate change is real. So we have a precedent for people ignoring science when it's convenient. But we know that disparities are real. And furthermore, we know that they contribute to avoidable high costs managing recurrence and death that could otherwise have been avoided. So it is important for all of us to think not only from a justice perspective or a compassion perspective that we want to provide equitable care, but ultimately, it means that we're driving costs in a system that's already burgeoning with costs it can't afford, that in ways that doesn't make sense from a financial perspective. So that is unfortunately the argument we have to offer to people who don't necessarily take the social justice angle. What do we do about it? My area of research is to focus on modifiable risk factors. That is to think about ways in which we can actually move the needle on disparities and no longer simply describe all the ways in which things aren't going well for certain groups of people. Modifiable risk factors include things that we can change about the patient experience, about the treatment experience, about the provider's interaction with patients, as well as about the system. So things that can include modifiable risk factors. We know that people who have a primary care home have a better likelihood of having better treatment for all of their conditions, including diabetes, high blood pressure, etc. And we also know that the inability to control those conditions when you're getting cancer treatment makes it more difficult for you to successfully complete your cancer treatment in a timely fashion. And yet, we know that in the United States, there is no real safety net ensuring that everyone has a primary care home. We spend more money than any other country in the world on our healthcare, and yet we have some of the worst approaches to preventative medicine on the planet. First things first, we need to do more to shore up our primary care system and connect patients with primary care providers. There's a lot of evidence that that will allow patients to have connections with doctors who they see before, during, and beyond their cancer diagnosis and treatment. And that relationships, longstanding relationships with primary care providers can hopefully raise the quality of care these patients receive along multiple dimensions, including their cancer. 2, we need to work on diversity in medicine. We need to have more doctors from diverse backgrounds acting and thinking about the ways in which we can provide equitable care. Now, I offer this with an important asterisk. While we know that racial and ethnic concordance, that is having a doctor who looks like you, contributes to better outcomes in many respects, it is not the answer for everything. There are other studies that have shown that even in situations where there is racial ethnic concordance, sometimes there is perceived disrespect by the patient from the individuals who are treating them. And there are many reasons that can happen. One is that as a system, medicine has not earned the trust of our most minoritized and poorly treated members of our society. So even if you are a person of color who belongs to the same group as the individual you're treating, that doesn't necessarily mean that they think that you are on their side. Secondly, we know that people of color tend to go to places where other people of color are treated. And the truth of the matter is, a lot of Black and Latino patients find themselves going to safety net clinics and clinics in areas where the staff is overworked and the space is overburdened, which means their overall quality of care is one that is not at the same rate as someone who can go to a place where there's more space, more providers, more time to take care of them, and address all of their needs. And so that is, and then finally, there's just the practicality of the fact that we don't live in a world where every single patient can have a provider who's the same race or ethnicity as she is. Nor do I think that's what we actually want. I think we want to get to a point where we don't have to rely on having a Black physician if you're Black or a Hispanic physician if you're Hispanic to be sure that you get high quality care and that you're treated with respect. Diversity is important because it improves everyone's ability to care for other people, and because it means that the space in which medicine is provided can be one that is imbued with trustworthiness, open-mindedness, and cultural respect and competence. So that is one reason we need to diversify medicine. And then finally, One of the modifiable risk factors we really need to address is making sure that as part of having connections with primary care, we are also conducting research that actually includes a diversity of patients. Back in 1995, the US Congress passed the NIH Revitalization Act, which was an effort, a bicameral, bipartisan effort, which seems fairly remote these days, to try and improve the number of individuals who were women and people of color in NIH-funded research. And what we found through research that my group and others have conducted is that really there are still huge disparities with regards to the diversity of clinical trial enrollment and participation. Black and Hispanic patients continue to be less likely to be enrolled in trials than white Americans. Immigrants are also less likely to be enrolled in trials than white Americans. In our work, notably, we have found that the disparities we see in terms of racial participation actually run counter to some people's expectations with regards to income. So you've actually found that higher income Black and Latino patients are less likely to participate in trials than lower income Black and Latino patients. And there are a lot of reasons to be potentially concerned about this. One, we also know that Black and Latino patients are much less likely to participate in phase 3 trials, that is, trials that specifically test the efficacy of a medication or intervention that's so far passed through first in human trials, phase 1, as well as kind of efficacy trials, phase 2. They are more likely to be enrolled in phase 1 trials, which are first in human trials. They're the trials that are highest risk and have the least potential benefit to the individuals who are participating. So what does that say about how we are counseling and engaging patients in research? What it tells us is that we may be exploiting patients' understanding of clinical trial mechanisms. We may be, in fact, using therapeutic misconception to have more vulnerable patients in higher risk aspects of the trial that are actually of less good to them, while not including them in the part of the trial that is closest to marketing, where there's been the most vetting and there's the greatest potential benefit to the individual. We have a lot of work to do. And we need to realize, in the same way that not all people from the same background vote the same way, not all people from the same background choose to engage with healthcare in the same way. We need to change our targeting in terms of enrolling people. We need to engage communities and not just individuals in the clinical trial process. Open science needs to involve bringing communities to the hospital, bringing science to the communities, and ensuring that by engaging people of all backgrounds in the idea of clinical research before they even become a subject, they are open to the idea of being a part of research and also open to supporting their family members who can consider it as well. Those are 3 examples of ways in which I think we can modify the way in which disparities are currently, unfortunately, perpetuated in our country with regards to breast cancer. The truth of the matter is we see disparities even in cancers that are more common in people of color, and therefore there should be more people who can be studied and understood in terms of trying to fight these diseases, such as prostate cancer and multiple myeloma. Breast cancer, I recognize in some ways, is a very privileged cancer in that there's, relatively speaking, a lot of funding and a lot of support. We have NFL players wearing pink sneakers in October, and we have a lot of runs and walks and parties. But for our patients who are going through breast cancer, this is not a party. It's not about pink balloons. It's not about celebration. It's about getting through every day. And so in talking about this topic and joining you all today, I want to encourage you to think about the fact that after the October passes, after the leaves have fallen, after the balloons are deflated, there are still people sitting and living there with their cancer and what cancer has done to their lives. And recognize that in a pandemic that is otherwise distracting the rest of the planet, it feels even more at some level inconsequential to have cancer, even though cancer is still the thing that dominates their lives more than an imagined viral scourge. And so in closing, I want to encourage you all to think about what you can do in your individual lives as future or current practitioners of medicine to make sure that every woman, every man, every child who comes to see you is treated with the respect that you would want, and that you can encourage that in your colleagues as well, so that together we can collectively practice more equitable medicine. Thank you.
Thank you, Dr. Fayanju. Any questions?
That was powerful. It really was. Like, it was I mean, if there's no other way to end the SOSA conference, that was the way to end it. I want to personally thank you for that as someone who sits on the board of SOSA. We've got a few questions, I'm sure. One of the questions I wanted to ask first, you mentioned that breast cancer is common in the LBGT community, and I'm curious to know, I've never heard that before, and I'm really curious to know what is the correlation with that?
So obviously there's diversity in the LGBTQ community as there is in any community. So amongst women who identify as lesbians, there is a concern there might be less engagement with the healthcare system for various reasons, including higher rates of uninsurance, as well as difficulties with the previous encounters with the healthcare system that may diminish trust. In addition, because lesbians are often less likely to have also had children, and we know that either nulliparity or late parity is associated with slightly higher risk of breast cancer, that also increases the risk of breast cancer. There's also higher rates of smoking in the lesbian population, which can also be associated with some cancers. Among people who identify as transgender female, that is people who had male sex assigned at birth, there is the provision of exogenous estrogen that actually increases their risk potentially of breast cancer. And then amongst people who are transgender male, even if they're not receiving any type of exogenous testosterone, many of these individuals may have avoided mammograms or other types of gynecological screening because frankly, it's dealing with the part of their bodies they may feel very uncomfortable engaging with, and that they may feel real trauma going through those types of surveys and those types of screens. And so the important thing is to make sure that whatever space you're providing care in, that it's not gendered in a way such as to make people feel uncomfortable to come. You know, I think about the fact that, frankly, pink isn't one of my favorite colors, and nor does the space have to be festooned with pink to be welcoming, right? And so that way you can have people who are transgender male, as well as cisgender men who can come because they too get breast cancer, into a space where they don't feel all the more out of sorts with the people around them. We need to meet people where they are, and we need to anticipate the ways in which having these types of screens and treatments can really be very upsetting with regards to how it may run counter to their identification.
Yeah, that makes absolute sense. Thank you for that. Thank you for that. So we do have some hands raised, Dr. Lowe, and then after Dr. Lowe, Kayla.
Hello, thank you very much for that talk, Doctor. Just two short ones. I'm wondering what your opinion is about the new thrust towards using ultrasound to screen. For example, in Switzerland, they have almost completely done away with the mammogram, and there is a movement in the UK now to do away with it. And it was explained to me here that African American women African diaspora women might have more minor calcifications than Caucasians, and so the mammogram would still have its place. And the second one is, I've almost given up being the voice in the dark at all the meetings I go to for breast cancer about diet. Is there any place for diet change in the whole of cancer anymore for anything?
Well, I'll start with your first question. So with regards to screening, you know, the truth of the matter is ultrasound is a very technician dependent modality. And so in areas and in centers where there is a very, very frequent and high quality use of sonography, then it can be an important adjunct to mammography. But as far as I know, and again, I'm not a breast imager, the only modality that's been associated with actual improved detection of early stage cancer is mammography. Now that may differ in different contexts. It might be they've done studies in Europe, which tend to be more homogeneous populations where that has been successful. But in the United States, I don't believe we've currently seen that. There is some recent research about using abbreviated MRIs, which is a kind of a lighter version of the MRIs we currently do for breast, that seem to be good screening modalities for women who have very dense, extremely dense or heterogeneously dense breasts, that there seems to be increased ability to detect otherwise undetectable cancers. But I don't think the data has really been supported yet for ultrasound in that regard in the United States. And this brings me actually to an important point, that when we go about adopting particular guidelines in the United States, which is a very heterogeneous country with regards to racial and ethnic diversity, access to care, diet, other comorbidities, and we base our recommendations on studies coming out of Europe, we need to be very, very careful. Several years ago, the USPTF, which actually guides the guidelines for many government-run agencies, including the military hospitals as well as the veteran hospitals, they came out with a guideline that said an average risk women could potentially do mammograms every other year. And in making that kind of claim, which was based on data obtained mainly from Sweden and Northern Europe, they really weren't taking into account what I mentioned at the beginning of my talk, namely that Black women are more likely to be diagnosed at a young age, as are Hispanic women, as are Asian women. So when you make that kind of claim and you don't think about what the downstream implications are for your already most vulnerable patients, you really aren't thinking at a population level about the implications for disparities. With regards to your second question on diet, I think that part of the reason people have kind of swerved away from diet is just because the data is not kind of wonderfully clean, but I think that there definitely is kind of a regulation or a recognition rather that we all need to eat less and move more. And that what we eat should definitely be more plant-based and less, stocked in kind of animal products. And so with regards to patients, when they ask me, what is it I can do about my diet? I tell them, don't buy what you shouldn't eat, because if it's not in your house, you can't eat it. So if you have things in your house that are healthy and things in your house, that means that when you are really hungry and the only option is an apple, you'll eat that apple instead of eating a bag of chips. And so that's kind of my general guideline to patients. But I also recognize that, cancer is a stressful time. People often eat for comfort. And so again, put things in your house that will make you comfortable, but won't make you sick.
Very nice, doctor. Thank you so much.
Absolutely, I agree. Kayla, are you there? You can take the
Yeah,
mic.
I'm here. Yeah, thank you for a great presentation. I'm at the public health school over at UNC and in the nutrition department, and we've been doing a lot of research recently about weight stigma and how healthcare providers' implicit bias against people in larger bodies can have negative effects on cancer screenings. And I was wondering if you came across any of this in your research, and if you could just talk a little bit about it.
That's a great question. And it's not something that I particularly done too much research about, though we actually have a paper we're working on right now looking at the effect of BMI on breast cancer outcomes. But there is a lot of evidence of stigma with regards to obesity, and a couple of interesting findings. So one, there was a study conducted by Jennifer Griggs at University of Michigan, I think in the mid-90s, which showed that people who were obese were regularly underdosed for their chemotherapy. They were less likely to get the appropriate amount because medical oncologists typically dose chemotherapy according to body surface area, not BMI, but then they try to do ideal body surface area. So they will assume that there is some different kind of calculation. Again, I'm not denigrating my med-onc colleagues who are amazing and have the reasons for doing what they do, but nonetheless, there seems to be a lot of evidence for the fact that they are more likely to give less chemo to people who are obese than they otherwise might need. And as there are higher rates of obesity amongst women who are Black and Latino, the concern is that they are systematically getting less chemotherapy than they deserve. In addition, there are many providers, as we found in some of our qualitative research, who conflate diabetes and obesity. We recognize that there is significant overlap between, in particular, type 2 diabetes and obesity. However, people sometimes stop giving a treatment or approach options for treatment based on assuming someone has diabetes versus the fact that they might just be obese. And in addition, we know that BMI is an imperfect assessor of obesity as well. And so the concern is that we do bring bias to these situations, that we may prevent patients from, let's say, getting plastic surgery because we have these arbitrary BMI cutoffs that disproportionately hurt women of color and that aren't really tied to their actual wound healing ability or predisposition to high levels of sugar in their bloodstream. Excuse me.
Thank you.
Awesome. So we have another question. So you mentioned that the data now shows that it's not the fact that African-American women or Black women are triple negative that is playing such a humongous role in their death rates. But if they're triple negative, they're not able to get targeted therapy. So in terms of getting targeted therapy versus general chemotherapy, is that still not making a difference in their death rate?
So targeted therapy, you mean HER2 positive, or treatment for HER2?
Or yeah, or receptor or like estrogen positive. Yeah.
Yeah, so in terms of the terms we usually use, I think most of us think of endocrine therapy as endocrine therapy, and then targeted therapy as typically kind of biologic therapies that are targeting the HER2 receptor, and then chemotherapy, which is cytotoxic. That is, it kind of attacks all things when they're most vulnerable and turning over them really quickly. And so, yes, if someone is triple negative, they're ineligible for endocrine therapy or for targeted therapy. They can only get systemic therapy. And we know that that's a very big hammer, a big, very imprecise hammer for a relatively small nail. And so we do know that HER2 positive disease is slightly more common in Black women and in Latina women, but the difference is not as great as with triple negative breast cancer. And rates of HER2 receptor or anti-HER2 treatment are a little bit lower again in people of color, and also a little bit lower in people from rural areas, in part because it's a year-long treatment. So the way that HER2 treatment typically works is that the first batch of it is in combination with chemotherapy and delivered via port. But then you're supposed to take a full year's worth. So even though there's that interval where you either get surgery or you get surgery before you start your chemo, it's a full year of treatment. And so having to continue treatment, which is Herceptin or Perjeta, typically every 3 weeks for a full year is really hard for many patients. And so we do need to improve access to that and adherence to that. But with regards to, again, closing the gap in disparities, we do still need to do a better job at getting women diagnosed earlier. We do still see much later stage disease diagnosed women of color. Actually, it's interesting that even though Latina women actually have higher overall survival from breast cancer compared to white and Black women, they're diagnosed at younger ages and they're diagnosed at later stage. And the reason that's important is that even if these women ultimately live quite a long time, if they present with later stage, it means they're more likely to have lymph node dissections, radiation, chemotherapy, things that can have long-term sequelae that affect their quality of life and compromise their ability to participate in the workforce. And so there are long-term implications to late stage diagnosis, even if ultimately one has good survival.
Absolutely. Another question has come in. So are mastectomy rates different among races?
That's another great question. And yes, so historically, lumpectomies are more common in the United States. Lumpectomies continue to be more common in Black women typically than amongst white women. Reconstruction is way more common. That is, having mastectomy and reconstruction is way more common amongst white women. And then amongst Latino women, we actually see pretty high rates of mastectomy without reconstruction, which, as I mentioned before, is really unfortunate given that they are also some of the youngest patients we see and have the most years to live beyond their cancer diagnosis. With regards to why we see these trends, we think they're related to a number of factors. One, as I mentioned before, Black women tend to have slightly higher BMI and larger breast size, which means that actually their breasts may be more amenable to lumpectomy. The same size tumor that would dominate a smaller breast actually only constitutes a smaller part of their breast, so they're more likely to be able to have a lumpectomy successfully. Two, because again, many women of color are higher BMI, they may actually be discouraged from getting plastic surgery or even turned down by plastic surgeons. Many plastic surgeons have a cutoff BMI of 35, no questions asked, above which they will not do reconstruction of any kind. And that is very hard for patients to hear in the same moment that they are finding out that they've been diagnosed with cancer. And then finally, with regards to why, again, we don't see it as much amongst women of color, there are concerns about the number of procedures that go into reconstruction. It really is a journey. So there's often the first procedure at which either a tissue expander can be placed, or even if someone gets a flap, which is using your own tissue to make a breast mound right away. In either of those cases, almost always there are additional procedures to either expand the tissue expander until a permanent implant is placed at a second surgery, or there are additional surgeries involving fat grafting and scar revisions, et cetera, because plastic surgeons, again, that's their job, like are perfectionists. They want it to look great, but for a lot of women, there's a lot of fatigue associated with those repeated procedures. And sometimes those procedures even get in the way of getting treatment, right? So they're in the middle of getting all of these plastic surgery procedures. Maybe they have a healing problem, and then they can't start chemotherapy, or they can't get radiation, which is really what they need at that moment. So I've definitely seen that as well. So lots of reasons why we see these disparate rates of reconstruction and different rates of lumpectomy versus mastectomy. And I also found that historically, many of my Black patients, when they get mastectomy, often choose to decline reconstruction.
So I have a question about the ductus in situ. So is that seen common in African American women, and do you recommend lumpectomy or mastectomy with that?
So DCIS is still seen amongst Black women as well. As with white women, it's diagnosed a little bit less frequently. But DCIS in and of itself is not a threat to anyone's life. It's when these cancer cells are confined to the duct. And the only reason we remove them, especially if they're higher grade, is that there's the concern for progression to invasive disease. In terms of whether one has a lumpectomy or a mastectomy, that depends entirely on the volume of DCIS. If you have a very small area of DCIS, then a lumpectomy is completely reasonable. But if there's a large volume of DCIS, even though it's technically stage 0 non-invasive cancer, mastectomy might still be the appropriate response in order to remove all the cancer from the body. And that's a hard thing for people to remember, is that how can I have stage 0 cancer, but need to have a mastectomy? And that's because stage is driven not so much by the size when it comes to DCIS, but by whether its invasive potential has been realized. So DCIS is stage 0 because it technically can't leave the breast, but it can still be large volume. And so therefore you might still need a mastectomy. The way to think about it is imagine that you have a house that's full of pipes, and imagine that on a cold winter day, all your pipes get frozen, all the water in your pipes is frozen. If your house is forever going to be frozen, let's say your house suddenly entered an Arctic vortex, you need a new set of pipes. You need a new house because there's nothing you can do about it, right? But as long as those pipes don't crack, your house won't get wet. That's DCIS. But if you have pipes that are fine, but you have one crack in that pipe, that means the water can go anywhere else in your house. That's invasive ductal carcinoma. So it's really about whether or not the cancer is confined to the ducts or whether it has the ability or potential to go elsewhere. That's what drives how we treat things.